Excellent. Okay, I want to thank the organizers of the MCPOP conference for inviting me to speak today with all of you about one of my favorite topics, the care and management of the micro-preemie. And my slides are, of course, not going to advance. Okay, so I have nothing to disclose. Our learning objectives today will include understanding trends in morbidity and mortality of very preterm infants. Well, talk a little bit about the innovations in care that have happened that have really impacted outcomes for these babies. We'll talk about some of the current approaches to micropreemie care and a little bit about the horizon, what comes next. So this is a slide from the CDC, and it's looking at birth weight specific mortality in 3 different epochs in the United States, 1950, 1985, and 2008. And if you look at these graphs, you can see the solid line is the mortality in 1950 down to the small dots, which are 2008. And you can see that mortality has really improved, particularly for our lowest birth weight infants. But if you look at morbidity, things really haven't changed quite so much. So this is data taken from the Neonatal Research Network, looking at different types of morbidity in infants that are 22 to 28 weeks gestation. And each of the solid circles represents the percentage of babies with that morbidity in this gestational age grouping in that year. And you can see really just looking at it, most of these lines look pretty flat. We really haven't changed too much. And in fact, in this data set, the rates of BPD actually went up a little bit. And late onset sepsis is our only winner here. You can see it sort of goes down a little bit with this, this line here. The good news is here in California, we may be making some strides. This is a recent publication by Henry Lee in Pediatrics in 2020, looking at data from the CPQCC from 2008 to 2017. And they looked at 49,000 babies in this low gestation and low birth weight category. And did see that survival without major morbidity actually increased from 62% to 66% during this time period. So that's excellent news for our babies in California. And really a lot of the improvement was driven by variation reduction in different sites. Certain sites that were not having it, outcomes that were as good really showed some improvement, and that drove these numbers. But the largest improvements were for necrotizing enterocolitis and in nosocomial infection rates. But again, BPD rates did not change significantly. So this remains a target for intervention. So when you look back at history and think about what has made these improvements possible, there are a few things that really stand out. Antenatal steroids was one of the big ones that has really become standard practice, at least in the United States, and has led to great improvements in micropreemie care. Surfactant also was very helpful to us. We've improved our ability to support ventilation in these babies with more lung protective strategies, and which we'll talk a little bit about that in a minute. We understand more about the use of breast milk and how it might be important for the care of preterm babies. And then we've also sort of specialized on the care of this gestational age grouping, and using specialized units, specialized protocols, we've been able to improve care outcomes. So if you look back, the first group that really targeted this small baby cohort and tried to improve outcomes and then published it was Nationwide Children's. And this is a publication from 2009 where they created some special protocols really targeting respiratory care in this in kids, I believe it was less than 27 or 28 weeks. And what they did is they encouraged everyone to use CPAP for these babies. And they had protocols to try to extubate them early. Um, they did not cohort them in the same room. It was just some respiratory protocols. But they did improve their survival without BPD once they started their small baby group compared to a comparison group in a previous epoch. They also improved survival without severe IVH and survival without BPD or severe IVH. And this really led people to think about how they were taking care of the babies, and that maybe some guidelines or protocols could help improve care. So Children's Hospital of Orange County was a leader in this space as well. And they published their data in 2015 about the results of their small baby program. They had a separate space for their small children. They chose less than 28 weeks and less than 1,000 grams. And they had a multidisciplinary team. I believe they still do, it's not historical, who take care of these children with ongoing education and process improvement, really targeting this population. They have evidence-based guidelines and standardized checklists they go through for these kids. Their primary driver initially was to reduce rates of chronic lung disease, but they really were looking at improving all of those morbidities that we looked at on that previous slide. And if you look at their outcomes, they really did see some improvement. Chronic lung disease, there's a trend for improvement post-intervention here. They did show improvements in successful extubation at 1 week. They did improve rates of babies who just needed CPAP, who never needed to be intubated, dropped their nosocomial infection rates, dropped their rates of growth restriction, and also reported reduced severe IVH, changing that from 46 to 24%, and shorter length of stay for their babies too, down to 104 days. I'm also going to highlight one other small baby unit, and that's the one in Iowa, who's really been doing some interesting work around their babies. And we'll talk a little bit more about them in a minute. But they have pushed the edge of what they standardly care for in their unit down to 22 weeks, and have published some outcomes for those children that are sort of intriguing. When you look at this data, and this is from a fairly recent publication of their outcomes, they're just looking at this is how their babies do in their small baby unit at these very low gestational ages. So you can see that their survival to discharge among even 22 and 23 weekers is 78%, which is a pretty impressive number compared to what many of us were taught during training, and certainly different from what the NICHD calculator will give you for these children. If you look down through the rest of these morbidities, it continues to inspire you with with rates of severe grade 3 or 4 IVH at 15% in the 22 to 23 weekers on average. And their neck rates are also listed here. They do have high rates of chronic lung disease. If you save these children, the things that they're doing does get them these impressive morbidity numbers, but due to that degree of respiratory immaturity, they pretty much all qualify as having BPD. So since these data were published, it really has caused a blooming of small baby protocols or small baby units. This is not a comprehensive slide of all the small baby units that exist in the country, far from it. But for those of you who are here looking at this from the Bay Area, we do have small baby units at both Lucille Packard Children's Hospital and at UCSF. But there are also some in more Southern California. So there are centers that are really concentrating on the care of these small babies and tracking outcomes. So I'm going to now talk a little bit about our experience at Lucille Packard. We started our small baby unit in August of 2017, and we call it the Nest. So you'll see we have some photos that are nest related in here, but we decided to focus on babies that are born at less than 29 weeks. And we chose this because it allows us to compare our outcomes to some national standards. So for instance, the Neonatal Research Network uses the cohort of less than 29 weeks and publishes data from that national cohort. CPQCC also uses it, Vaughan, and so it allows us to compare ourselves to others. So when we did this, we created some specialized protocols around the care of babies. I'm going to share some of that with you today, but with the goal of trying to work on all of those same morbidities you saw on that previous slide, and really try to see if we couldn't move the needle on the care, the outcomes for our kids. We do have a separate space for these babies. We do cohort them, although we don't have a separate team. But we do have specific educational programming for all people who take care of nest babies so that people are educated on the protocols and the reasons for them. And we've been doing a sort of a refreshment of that education intermittently to keep people up to date and of course, have those protocols in the front of their minds. We also annually track this data and talk about how we're doing and explore opportunities for improvement. I will say I'm proud that we've made a few gains from our work. We have pretty much eliminated hypothermia in the delivery room. We had rates of hypothermia there that we were not proud of initially. And although every now and then someone will tell me we've had a baby who is somewhat cold, we pretty much have eliminated that entirely. So that's been incredible multidisciplinary work to do that. Our protocols have also produced a reduction in chronic lung disease by 15%. We've reduced our growth failure rates by 30%, and have increased our rates of developmental care activities provided by parents by about 5% overall. And that includes things like skin-to-skin care, reading, positive touch, etc. So I'm going to talk a little bit about our core protocol components. There are, more details to be had, and different centers do slightly different things. And I'm going to highlight where there might be still controversies or areas that we need to learn more. But I'm going to go through generally what we try to do. So of course, it all starts in the beginning. Antenatal care is really important, particularly antenatal steroids. That, like I said before, has been a very powerful mover for improving micro-preemie care. But then when you get to the delivery room, again, we focus on avoiding hypothermia, delayed cord clamping, and immediate CPAP. We don't have the babies prove to us that they need CPAP. The minute they are done with their delayed cord clamping, we bring them over and they immediately have CPAP applied. Of course, if they need to be intubated, we do that in the delivery room, following NRP guidelines. And then once we get to the unit, we really try to stabilize our baby using the platinum hour. Many of you may know this as the golden hour. There are other units use different names, but the goal is really to complete your stabilization in that time period so that the baby can get settled and rest. We target trying to avoid hypoglycemia with early glucose monitoring, trying to get our umbilical lines in and give surfactant if that's needed, intubate the baby if that's needed, and we have protocols that guide our care team about what oxygen levels and what blood gases would indicate the baby needs to be intubated for surfactant. We use bubble CPAP once we get back to the unit. That's been a new thing since 2019, I believe. And of course, are keeping the head in midline to reduce IVH. Our respiratory protocols, we try to use lung protective strategies in the early stages. Um, if you get to older preemie babies, the strategies change as they start to develop BPD. But early on, the idea is to try to use lung protective strategies to support them and hopefully try to avoid BPD. We do try to avoid intubation if possible, and thus the use of bubble CPAP, and not making them fail in the delivery room, helping them recruit their lung volumes and stabilize from a respiratory perspective. Um, if we do need to intubate the baby, we give them surfactant and put them on volume guarantee ventilation, which is a gentle ventilation strategy that's been shown to reduce BPD. If the pressures that they need using volume guarantee ventilation are very high, we use the high frequency oscillator to ventilate them. Uh, some places use the jet ventilator, but we have the most comfort with the oscillator, so that's what we're doing. And we also use early caffeine. So even if they're intubated, we give them caffeine because it has been shown to have improvements in lung disease and may have some neuroprotective factors. There are controversies in respiratory management. And so one thing that you learn once you start exploring other small baby units and their protocols is that we have differences among us. And I tell the fellows at Stanford that anytime you start seeing differences between centers that have really explored the evidence, it means that we probably have more to learn in these areas about what is truly the best care practice. So some of the controversies and differences you'll see among small baby units include when to use high frequency ventilation. Some places really like high frequency ventilation and do it as a standard therapy for all of their very small children just from the get-go. They don't even use the conventional ventilator. Whereas others are even slower to use it than we are. There's also the option between the oscillator and the jet ventilator. So those are two different tools that people are using when you get to high frequency. Another controversy is how long should they be on CPAP? I mean, we know that CPAP is a lung protective strategy, but how long should we be using it? Should we try to get them off as soon as possible? And if so, what should we wean to? Should we use high flow nasal cannula? I will tell you what we are doing at Stanford is that we are leaving the CPAP on our nest babies until around 32 weeks post-menstrual age at a minimum, because we feel like it helps support their lung growth and keeps them nice and stabilized. We don't tend to use high flow nasal cannula, and this I know is an area of variation among centers. The data on use of high flow as a replacement of CPAP, we feel is fairly clear. It's showing a superiority of CPAP in terms of keeping babies off the ventilator, but that interface is so easy for people, it's very tempting. So we do, certainly not before 32 weeks do we use high flow nasal cannula, but this is an area of variation. Most of the small baby units, though, are pretty sold on CPAP use, at least until they get bigger. Intubation and when to give surfactant guidelines also differ a little bit among centers. Some places who have really low rates of chronic lung disease actually allow FiO2 to get up into the 50s and 60s before they will intubate and give surfactant. Whereas other centers are more aggressive and do it more at 30% FiO2. We tend to be more in the 40 to 50% range, and this is really based on predictions of intubation need, like respiratory failure in the data. but there is some variation there. We also aren't sure exactly when to use postnatal steroids and which one to use. There's a lot of variability in what people are doing. Some are following standard hydrocortisone after delivery to hopefully reduce a BPD per the preemie lock protocols. Others are not using it at all. Others are only using steroids to try to get children off of ventilators later. So I think there's a lot of variation there and thus need for more data. And then, of course, the when to treat PDAs is a whole lecture in and of itself. We are using conservative management right now at Stanford, but there are ongoing studies to try to help us understand a little better when to treat the PDA, what time. So more to come on that for sure. All right, our protocols also include nutrition, and we practice early enteral nutrition. We try to get milk in the baby's stomach within the first 24 hours, if possible, if they're stable. And that usually relates to hemodynamic stability. If they're on high levels of pressors and things like that, really, acting very ill, we don't do it. But for the most part, all of our kids will get some milk in their stomachs day of life 0. And we are lucky to have donor milk at Lucille Packard. So if mom's colostrum is not available, we will get consent for donor milk and use that. We, of course, try to get colostrum as much as we can with early hand expression and pumping. But we are fortunate to have donor milk for this. We also do early and aggressive parenteral nutrition, trying to get starter TPN going day of life 0 and ramp up to higher protein levels so that we mitigate the growth failure. It helps improve your hypoglycemia and hyperglycemia that can happen with the small babies. And we also have feed advancing guidelines. So feeding protocols have been shown to get babies on full feeds faster, help improve growth without impacting necrotizing enterocolitis. Really important to the early stages of the care of these babies with fluids and electrolytes is to try to have controlled appropriate diuresis, because either not allowing the babies to diurese at all or having them lose too much weight, both are associated with less favorable outcomes. And so it's the dance that many of you know who take care of these babies, trying to really hit that sweet spot of around 8% or so, 8 to 10% of diuresis, while trying to avoid these sodium and glucose imbalances. It takes a lot of very detailed care. There are still controversies in nutrition management. The classic example is the Japanese care patterns are using low rates of total fluids that are going parenterally, but using very high humidity to mitigate insensible water losses. They are doing it that way. And in Iowa, they are not using humidity and using very high fluid rates. So when you have two people doing something so very different with good outcomes in both situations, it makes you know that we still may not know what we're doing there, but maybe it's fluid balance that's most important rather than which technique you take. I think we're still trying to understand when to fortify and with what. We have used Prolacta, we have used human milk fortifier, and change it up based on data. I don't think we've completely figured out what we want to do there. Sorry, there's a typo. The speed of feed advances. Also, some people, different centers have different protocols there. We have stopped checking residuals, the remainder of milk after feeds, because we think it actually slows the feed progression down, and the evidence doesn't support that it increases your neck rates, but Iowa still does it. So there certainly are centers who are monitoring the digestion of their babies. And then something we've been talking about recently, the use of probiotics. Some centers are doing this, some are not. And I think there's a ongoing work around these medications to help improve growth, maybe dropping neck risk, et cetera. So more to come there. And then the last part of this is really looking at neuroprotective care. And, certainly it involves IVH prevention, but also developmental care and how we take care of the baby longitudinally. So for IVH prevention, we're talking about antenatal steroids, delayed cord clamping, avoiding rapid changes in blood pressure and cerebral perfusion. So being careful with fluid boluses and how much you draw blood off the line. Optimizing respiratory support, because that can actually affect IVH risks. And midline head positioning, which people tend to talk about. The data on that is actually not hugely compelling, but since it's such a simple thing to do, we absolutely do it at Stanford. Neuromonitoring, we are fortunate enough to have both NIRS and AEEG, which are part of our standard monitoring for our smallest babies. We do head imaging with an ultrasound at 7 days of life. We have been doing an MRI at term equivalency, although we've been talking about it recently, about what type of term equivalent head imaging we might do. So I think that's another area of variation. We focus on reduction in pain and stress, and I have another slide about how we do that. Trying to use appropriate stimulation. So developmental care activities that seem to have benefit, things like kangaroo care and appropriate voice exposure. And then, of course, integration of our families into care, because we are really taking care of these babies for really a relatively short time in the child's life. And so getting the family into the whole care team is really important. So for pain and stress, for our babies who are nesters, we actually have every 6-hour touch times until 32 weeks. So this means that rather than every 3 hours, the nurse going in and doing a full care of the baby, she does it every 6 hours. Certainly, if something happens with the child, you can go in there and respond to cares. And at the 3-hour mark, she may hang more feeds or take a look at the baby, but she's not doing a full care. She's not changing the diaper, those kinds of things. And that allows for greater periods of time where the baby can rest and not be stimulated. We also use two-person care, which means when the nurse is going to go in to do her cares, or when the other members of the care team are going to go in and do something, we have a second person there who's responsible for doing containment touch or making sure the endotracheal tube isn't dislodged, things like that, to try to make sure we both mitigate pain and stress and keep all of our equipment in place. We try to make sure we use non-pharmacologic pain and stress mitigation and avoid benzodiazepines because of our concerns of neurotoxicity. And this means swaddling, using containment touch, using things like breast milk and oral glucose solution. Even kangaroo care can be a pain mitigator for these babies. And we do monitor our noxious stimuli with a POC score so that we are keeping track of really how much babies have already sort of gone through in a day. If we can move blood draws and things like that, we'll do it. Also, when you look at our unit, that place where we cohort them, we try to keep it at a lower noise level and a lower light level with starting cycled lighting at 32 weeks. But for those babies, we try to, understand that the stress of being outside the womb can be real for them and may, have negative health outcomes. In terms of appropriate stimulation, one of the things that we realized early on was that there was a lot of disagreement among our nursing staff and our provider staff. And then, of course, with the families about what types of sensory experiences were appropriate at what time. Although people sort of understood that it was good to do a lot of these things, they weren't sure, is my baby healthy enough for this or that experience? And so we created a guideline for our preterm infants that, based on their stability, gives doses and recommended developmental care activities for both the staff and families to do with the babies. We also track developmental care activities because we believe these are important for neuroprotection and neurodevelopment. We actually track them like a medication. And so they're in the EMR. And then we have a special developmental care team that follows them and nursing education around this. And then, of course, the family, there are high rates of depression and anxiety in our families. And so, and we know negative outcomes may come from parental health disturbances. So we're screening all of our families for anxiety and depression at 2 weeks into their stay, and do have the benefit of a dedicated psychologist and availability of group therapy for our families. There are controversies, like I said, the midline positioning, the data isn't that powerful. Some centers are standardly using Indocin to reduce IVH. Again, we talked about the postnatal steroids, and then various centers are using different guidelines for timing and dose of their sensory experiences. So I want to take our last minutes to talk about where can we go from here. I certainly enjoy the collaboration and putting our brains together with all of these other organizations who are working on the same thing. I think there's a lot that we can learn from each other. And so our group, goes to meetings and interacts with other small baby unit groups from other hospitals, which is really fun and can be really useful. I think the edge of viability is another area that we're really going to be focusing on in the next 10 years. Because like I say, Iowa is starting to really look at these small children and do some really interesting things with them. So the ACOG put out a consensus statement in 2017 talking about when we should resuscitate babies at what gestational age. And I think for some centers saying you should consider resuscitation at 22 weeks was surprising to some people. But there are, like I say, there are some centers who were doing it quite successfully. But this was meant to be a guideline to help people know what to do. Of course, really importantly, including the family input into these decisions. I think is vital to any plan you make for infant care. But if you look at gestational age outcomes, there's a lot of variation in how people are caring for these babies across centers and what their outcomes are. And we're sort of stuck because the NICHD calculator, which many of us grew up using, is based on really old data that may not reflect today's outcomes. And there's increased recognition of the importance that families' values need to be a central part of these conversations and our planning on what we do with them. And there's this paper by Rasavi that was in the New England Journal that said that active treatment of babies at this edge of gestation accounted for 78% of the variation in survival and 75% of survival without severe impairment. So it's less about the baby and more about what we are in fact doing. So when you look at the long-term outcomes from Iowa, it's interesting because when you look at their 22 weekers, they've got 30% on average died in their cohort, 70% survived a hospital discharge, and 35% had no or mild neurodevelopmental impairment. which is pretty surprising for a lot of us who, really grew up with that 22 weeks was really, pretty much the baby was not going to survive. And if they did, they were going to have a severe impairment. So there are people who are moving the needle here. And so it calls us to really look at what they're doing and think about what we would like to do to care for them, and really include the family in those discussions. But as I said, the challenges that we have in counseling parents is that our prediction models are old. And they may not reflect sort of what we're doing now. We are relying on ultrasound dating, which may be off. So even if you do early ultrasound dating, 5 days may make a big difference when you're talking about a 22-week baby. We also know that different children develop at different rates. And when you're talking about this window at 22 to 25 weeks, again, a few days may make all the difference in terms of if a child's respiratory system is more or less developed. There are other factors that aren't included in the NICHD calculator, which may be important to outcomes like maternal health, genetic things, etc. Our institutional practice patterns may affect our outcomes. And then the question is also, how does outcome prediction change over time? For instance, a baby who in the delivery room does well and only needs CPAP, how does that change our prediction of how that baby will do? And then, of course, family factors are also not considered in those models. So I think a lot of the exciting things that are coming is people are exploring the use of big data, integration of other clinical data into our models, allowing for changes over time. Again, if that baby does do well on CPAP and goes into the unit, how does that change our outcomes? Our future may include use of detailed monitor data like heart rate variability or biologic samples. And all of this really has the ultimate goal of improving our family counseling. And so we can make good decisions and inform what we do as an institution. And my last pitch is that I think the family is unappreciated as a modifiable factor in micro-preemie care. There are many ways for them to be an important part of this team, better understanding of their goals, and then participation in these important developmental care activities can also help improve outcomes. And my last slide here is there's a study by Bremen in Bavaria. They followed children born from the 80s, and they followed them to 20 years of age. And they looked at factors associated with cognitive outcomes at 20 years. And so many of the things were in there that we would predict, like RDS, IVH, et cetera. But a good parent-infant relationship also rose as a powerful factor, where a good parent-infant relationship was associated with a 5-point increase in adult IQ. And so make sure you're taking your parents into account when you're talking about preemie baby care. There's more for us to learn. Looking forward to it. Thank you so much. I'm going to stop sharing so I can see you guys. Hi, Christina, you're muted.
Good morning, Melissa. Melissa, I'm going to do a little housekeeping first, if that's okay with you. First of all, I want to welcome everybody. I'm Associate Director at CNQCC. We had a little bit of technical difficulties going on here. It's because we're just not all together in Monterey. That's why. But we welcome you. Our goal was to have everybody on screen right from the start. It appears that we've got that glitch is gone. If you're still not visually visualizing us, please go ahead and refresh your browser, or refresh your page. All right, and then you should have it. Melissa, stellar. I have to tell you that. And I have a few questions coming in, so it's very exciting. So the first one I want to get to is the question of, since you don't check residuals, how do you monitor for feeding intolerance or early NEC?
Yeah, so that was a difficult culture change, I will say, in our unit, because we used to check residuals. So many of you who are watching this, if you're a neonatologist, you'll know that that's a hard data point to let go of, because you feel like it is informing your decision about digestion. Most of what we do is really examining the baby's abdomen. So looking for abdominal distension over and above previous. And then we find that really, if the residuals are that bad, the baby's going to throw up. And so usually what will happen is, if you will go and examine a baby if they are having emesis. But a lot of the data actually supports not checking residuals and just using those two things, your abdominal exam and whether or not babies are having emesis, and just letting them work through some probably smaller residuals that you don't pick up, but those don't seem to be clinically, predictive of NEC. So.
So thank you. We're having some difficulty muting and unmuting here. I have another question. You don't seem to use HFNC. What about NIPPV?
Yeah, so we don't use NIPPV usually. Bubble CPAP itself is it's not NIPPV, but it does have oscillations that come with the bubbling, right? It's sort of akin to a CPAP with like a low grade oscillator background. So basically it is a version, one could think of it as a version of NIPPV, because you're actually having increased gas exchange with those oscillations that occur with the bubbles. We do occasionally use NIPPV, but we can't do it with our bubble CPAP apparatus. So it sort of was a trade we made. And truthfully, we were happy with that, because the data on NIPPV actually being that effective is not great. And if you're looking at trying to keep babies off the ventilator, there's a little bit of support for that, but it's not that compelling. So.
Got you. A couple questions have come in, and we want to talk about fortification of milk, right? So if you could speak to banked milk, to maternal milk, and then what is a consideration in preventing IUGR?
Yeah. So, mother's milk is the standard, and anything you can do to get more mother's milk into your child, is the best. There's some really interesting data that's shown that if you get mothers hand expressing or pumping, particularly within 1 hour of delivery, you can improve her future production of milk. So that's been one of the efforts that we've made at Stanford, is to really try to beef up our early hand expression for mothers. That took some education of our labor and delivery staff, because usually the moms are trying to recover and they're trying to get the moms settled. And so then we had to say, yes, but you also, while you're getting everything done, need to help her hand express. So, and they sort of looked at us askance at first, but it really is very powerful, actually. And the dads are usually so proud when they walk over with their little thing of colostrum. They feel like they've done something. But so that's of course best. But the problem is that, the association between formula use and necrotizing enterocolitis is such that we felt if we didn't have mother's milk, that banked milk was our best bet. And we know early feeding also can protect against NEC and help with growth. And so that's why we use banked milk as our sort of backup milk, as you will, right? In terms of IUGR, we're lucky to have a nutritionist on rounds with us. We actually have gone to some more aggressive feeding strategies where we're fortifying at more like 60 mLs per kilo per day rather than waiting till later. And that has helped support our growth. Of course, you're always sort of monitoring for tolerance, but I think just real care, careful attention to growth is really vital for these little guys. In the beginning, it's a lot of fluid shifts, but.
Yeah, I have one that we're gonna kind of a comment, and I'd love you to speak to this for a second, because I found this so interesting. And remember, I've been in healthcare over 30 years now, but this is about family-centered care. I caught something you said that I think is incredibly important. You mentioned that the family is a modifiable factor. I don't know if you, because if you should trademark that, number one, if you that's heard. I have never heard that. Speak to that for a moment, can you? Because that's very powerful.
Yeah, I think that if you look at the background of family-centered care in the NICU, there's some really interesting photos from the first NICU in Boston where families weren't even allowed to go in and the nurses were, all masked up. And I think for a long time, our attempts to keep families out was really related to infection concerns, and still is in many parts of the country. But, we are learning more and more that not only is maybe a not humane thing to do to keep families out, because this is their child, and the trauma that occurs for NICU parents from this separation and from going through a NICU stay is real, with rates of PTSD among NICU parents as high as 15%, which is just really, it's a trauma.
That's incredible.
Watching happen. But I think increasingly we are not only learning that there are health benefits of all of these developmental care activities that we don't either have time to do or really aren't our place to do, like skin to skin care. You're not going to have healthcare workers putting the babies on their chests, certainly not in our country. But there are all these health benefits that come from doing skin to skin. So that's why we started tracking all of those things like it was a medication, because it helps people understand how important those things are. And really there's that intriguing research talking about that parent-infant relationship as a predictor of 20-year cognitive outcomes. I mean, that seems crazy. But that's because we're starting at the beginning. And if you start on solid ground, it changes probably how the child is cared for, not only in the hospital, but once they go home.
Right. You know what, we're going to have to tie it up. Dr. Melissa Scala out of Stanford's Department of Neonatology and Developmental Medicine. We thank you today. Beautiful presentation. We welcome everybody to join Virginia Wynn in just a moment. Thanks, Melissa.
Thanks.